Good afternoon, and thank you for joining us for today's webinar. A few housekeeping notes before we begin. Can you go to slide 2, please? In this platform, all attendees are muted. While you won't be able to ask questions through audio, please note the Q&A function on your screen. If you have a question that is not addressed in the presentation, please submit through the Q&A feature, and our speaker will try to address as many as possible at the end. Also, today's webinar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link to view the recording once it's available. It is now my pleasure to introduce today's presenter. Next slide. Dr. John Coletta is a board-certified fellowship-trained interventional cardiologist with University Hospitals Harrington Heart and Vascular Institute. He is chair of the Department of Cardiology and the medical director at University Hospitals St. John Medical Center in Westlake, Ohio. Dr. Coletta earned his medical degree from the University of Cincinnati College of Medicine, followed by an internship and residency at University Hospitals Cleveland Medical Center. He went on to further advance his training by completing 2 fellowships, one in cardiovascular disease and the other in interventional cardiology, also at University Hospitals Cleveland Medical Center. Dr. Coletta has special clinical interest in the diagnosis and treatment of coronary artery disease, with expertise in performing coronary interventions. I'll now turn it over to Dr. Coletta to host today's presentation. Dr. Coletta, thanks for joining us.
Thank you, Tiffany, and thank you everybody for coming today. I appreciate you taking the time to join us on this talk today about heart disease. And I think it's always a good place to start to see some stats about heart disease in the United States. It is the leading cause of death for men, women, and people of most racial and ethnic groups. Every 34 seconds, somebody dies of cardiovascular disease in the United States. And in 2020, approximately almost 700,000 people died of heart disease in the US. Coronary artery disease was the most common, with close to 400,000 deaths. And 20 million adults aged 20 or older have coronary disease, and that equals about 1 in 13 people. And in 2020, 2 out of every 10 deaths occurred in patients or individuals less than 65 years of age. So it is not just of quote unquote older individuals. I think we need to talk about some early warning signs, and I think that there are some things that we can identify in terms of symptoms, as well as some findings that would help us to identify who may be at risk for coronary disease. So symptoms classically of chest discomfort, pressure left or mid chest radiating to the neck, jaw, or shoulders, usually worse with exertion and relieved with rest, and associated with symptoms such as sweating, shortness of breath, or nausea. And some of that reason is because the blood flow to the lungs could be abnormal, but different areas of the heart could be having decreased blood flow, resulting in some symptoms that would irritate the diaphragm. And sometimes we'll see nausea as one of those symptoms. Shortness of breath alone on exertion without associated chest pain could also be of cardiac etiology, as well as exertional fatigue or exertional intolerance. If you're walking and doing a routine exercise program and find that you just can't make it as far as you used to, that could also be a sign. I know that some of the words here are a little small, but I think that the slide was put in here to identify the fact that pain is a subjective sensation. People describe pain personally. And so although we will listen to, I will use the word chest pain, and someone might say they don't have chest pain, they have chest discomfort, or there's a pressure-like sensation. We have to listen as physicians to our patients, and I try to identify what they're telling us. But there are all these different descriptions of chest discomfort, which may lead us to a higher suspicion or a lower suspicion of ischemia or decreased blood flow to the heart. I think that I also want to emphasize that we have a phrase in medicine that time is muscle. And I think that this is very important. If you have symptoms and you're not sure whether or not these are symptoms that you should be concerned about, seek medical attention immediately. And if you have an acute onset of chest pain or comparable symptoms, dial 911. I've had so many people who've told me, well, I thought I could get to the hospital faster. The reality is that when you call 911 and trained professionals come to you, they can help identify the problem and even transmit an electrocardiogram or an EKG from your house to the ER. And this could shave 20, 30 minutes of time for the hospital to know what's happening and even to activate a cardiac catheterization lab. And there have been several studies showing that this really does improve outcomes. So if you're concerned, call 911. Diagnosis tools, there are several things that we have in our armamentarium of tools to look to see if this symptom that you're experiencing may or may not be from the heart. It all starts with the history and physical exam. We also use an electrocardiogram. We can use risk calculators. There's imaging testing that we can perform, such as coronary calcium scoring CTs, as well as different CT scans and MRIs. There are stress tests, and there are different types of stress tests that we will talk about. And there is cardiac catheterization, which we will touch upon as well. So what do we look for in the history? I think we are trying to extract symptoms that would be concerning for coronary disease, like the ones we talked about before: chest pain, shortness of breath, or exercise intolerance. We want to understand the characteristics of the symptoms. We want to see how it starts, what triggers it, or what alleviates it. How intense is it? How long does it last? And how frequently does it occur? We want to understand if there are associated symptoms like we discussed earlier. We want to identify associated risk factors along with the past medical and surgical history, which may bring us to an idea that this is more likely or less likely from the heart. Risk factors such as diabetes, smoking, kidney disease, to name a few. And then we also want to understand the family history, see if there may be a genetic risk for premature coronary disease. We also want to understand the social history. We call social history, there are different components we look at in the social history, such as smoking use, or tobacco use, smoking, alcohol use, other drug use. What is the situation at home? And where do you work? What kind of exposures may you have been a part of over the years? We want to know your allergies and your current medications and supplements, because those can also help us understand whether these symptoms may or may not be from a cardiac standpoint. There's a lot of physical exam features that can be associated with coronary disease, and I just wanted to highlight a few. So obviously vital signs: blood pressure, heart rate, height and weight. We want to evaluate the neck. There are neck veins and arteries that we want to evaluate to see if there are signs or symptoms that would suggest the heart is involved with the current situation. There's the chest exam, and we want to listen. We call that auscultation. We will listen not only to the heart, but also to the lungs through the stethoscope. And we will also palpate, touch to examine consistency, tenderness of the chest wall, and even potentially feel the pulse of the heart to see if it's displaced, if there's evidence of an enlarged heart. We do examine the pulses, potentially in the extremities. We'll evaluate for signs of swelling, which may tell us that the heart is dealing with too much fluid and the legs may be swollen because of that. And as we talked about, we'll also examine the lungs. But this is just a few different things that we will examine while you're there at the office. What about the electrocardiogram, so the ECG? This is really a recording of the electrical activity of the heart. It's almost a fingerprint of the electrical signaling of the heart. Unfortunately, it doesn't always change when there is coronary disease. And so there can be a normal electrocardiogram. There can be non-specific changes, meaning that you don't specifically, you can't specifically tell what the problem might be or whether there is a problem at all. And this can lead to suspicion of previous damage. You can see signs of a prior heart attack potentially. And there can be signs of suspicion of an acute injury or something going on today. There's also a 10-year atherosclerotic cardiovascular risk calculator. You can all look online. This is a free tool, and this helps to identify or determine the risk of cardiovascular events over the next 10 years. And it can be kind of divided out into low risk, borderline, intermediate, or high risk. And those are associated with the percents that you see there: less than 5%, 5 to 7.4%, 7.5 to nearly 20%, and then greater than 20% risk over that 10-year period. This will utilize different aspects of your demographics, your age, your gender, different risk factors, blood pressure, cholesterol readings, and you'll go through and you can identify your 10-year risk. This tool can help with determining the impact of different therapies. So not only will you see your risk, but you'll see if you were advised to add aspirin, if that would help, or if you were to be advised to use cholesterol medications, how that might help. The U.S. Preventative Services Task Force is a federal agency that will look at the utility of doing different things and the impact on patients' lives or livelihood. And what was recommended is that you could use this 10-year risk to identify patients and to treat them differently according to the risk through the calculator. So I don't want to go over this slide in detail, but suffice it to say that this information is recommended to be used by primary care physicians as well as specialists, cardiologists, to help treat individuals and their individual risk. So moving on to diagnostic imaging, we have a lot of different tools, a coronary artery calcium scoring, computed tomography or CT scan. This is non-contrasted, meaning we don't use IV dye. And it's a CAT scan that can be used to look for signs of atherosclerosis or cholesterol buildup. What happens is that different than the sink in your bathroom drain, that if it clogs, you just pull the clog out. When cholesterol builds up within the artery senses that and recruits white blood cells or infection-fighting cells to come in and eat the cholesterol within the wall of the artery or within the metal of that drain. When that happens, the white blood cell changes as it eats the cholesterol particle and it gets caught there forever. And what will develop is little pieces of calcium will be deposited, not because of anything you may have been eating, but because of this change in the white blood cell. And that calcium is a metal. It's now stuck in the artery forever. Metal shines differently than soft tissue. And if you do a CT scan or a CAT scan, you'll see that there is identification of calcium or metal in the arteries, and that would identify this atherosclerosis or cholesterol buildup. So apart from just a coronary calcium scoring, there is coronary CT angiography and heart flow analysis. This is a different type of CT scan, CAT scan, where we can obtain 3D imaging of the heart, the coronary arteries or the heart arteries, and other great vessels such as the aorta or the pulmonary arteries. And we can assess whether there is blockage and how severe that blockage might be. This does require IV contrast, different than the CT calcium scoring. So there are differences in the testing. We can also do cardiovascular magnetic resonance imaging or an MRI of the heart. And this can be very helpful. We do not use ionizing radiation. There's no X-rays with that. We do have to use contrast. And so we do also have to watch out for issues with kidney dysfunction, which may limit our use of contrast in certain individuals. But it can be used to diagnose and monitor different heart and vascular as well as valvular conditions in someone, limiting the amount of ionizing radiation or X-rays over time. Just a quick word about coronary artery calcium scoring or CT. This is on our website, and you can search this and it will describe the process, and if you have an order or if you don't have an order, kind of how to navigate through that system. It gives you an explanation and a video of what you would anticipate, but it's about a 15 to 20 minute test. There's no IV like we talked about. You kind of get the test performed and then you can leave, and this information will be sent to the person who ordered the test for you. Who should get it? There is a further down on the page, the same page that you can look. Men or women age 45 or older with no history of coronary disease. So if you've already been diagnosed with coronary disease, this is not as helpful. What we're looking for is to identify people who may be at risk who have not been identified to have coronary disease, with one or more of the risk factors listed below, including high cholesterol, low good cholesterol or low HDL, high blood pressure, cigarette smoking, diabetes, and other inflammatory diseases can also increase the risk. So this would be a good test to identify who might be at risk and someone who may need further evaluation or testing to see if anything is going on that they're unaware of. You may have seen some of these articles either in the newspaper or on television. There was a lot of press recently. Dr. Al-Kindi is one of our cardiologists at UH who talked about how this no charge or free coronary artery calcium screening really has impacted what we do and for whom we do it. We have found that it can reclassify patients to see if they should be on statin therapy or if they're statin eligible. It has resulted in changes in preventative strategies, how we look at populations of people and how we can address disease that we were ignoring in the past. And it has shown to improve risk factors in often underrepresented groups, such as women, African Americans, and people living in lower income communities. So this was using this information to really help the people of our community. And I really wanted to just call out Dr. Al-Kindi and the group at UH for doing this. When we talk about imaging, and people will ask me, well, is this going to tell us if there really are blockages that are going to get us in trouble? I kind of equate imaging and then stress testing, let's say, to the difference between looking at a diagram and actually testing out something. And this is an example. If we have a diagram of your plumbing in your bathroom, we might see that everything is plumbed accordingly. The drains are there, the vents are put correctly, but we have no idea if your bathroom is working until you turn the faucet on, right? You want to see, is there a blockage in that drain? You can't tell that by a diagram. So not always will the images help. Sometimes we have to move on and open the faucets. We have to take a look at how things are working. And that's where we move into ideas like stress testing. So there's different types of stress testing, and we'll go over a few of those quickly. Treadmill stress testing, you can see a picture of what you would anticipate there. We assess the heart's response to exercise. We have an ECG or an EKG that's attached to you, and we have blood pressure cuff that's attached. And we monitor both these as you walk on a treadmill. There are different protocols of how fast and how high the incline will go, and every few minutes those will change to increase the level of stress. And so we call it a graded process. So you have a graded protocol that will increase the amount of exercise that you need to perform. And we stop the test either when we identify high risk findings or when someone can't keep moving. So we kind of go to a point where you feel like you gave it your all. Sometimes that is not going to be exactly helpful in determining everything that we need to see. Sometimes the EKG is not interpretable, and so we may have to add imaging, or maybe there's something else we want to see. We can do something like a stress echocardiogram. This is a stress test either with a treadmill or a pharmacologic agent. We'll call that a chemical stress test sometimes. And what we see is that we can, with the treadmill part, we would do a similar treadmill stress test, but beforehand we will take pictures of the heart with an ultrasound or an echocardiogram. Then we will get on the treadmill and do the same type of stress test that we just talked about. And as soon as we're done and you say, okay, enough's enough, we'll get you right back over to the bed where you had the initial pictures, and we'll repeat the pictures and try to see a before and after. If we're using a chemical, what we'll do is we'll take pictures with no medication, and then we'll slowly increase the medication, take pictures until we get to a peak medication to see how well the heart is pumping. We can see not only if there is old damage to the heart, but if there are severe blockages that would need to be addressed further by this testing. Another imaging type of stress test is a nuclear stress test. This is also referred to as a stress myocardial perfusion image or scan. And we can, again, use either treadmill or pharmacologic agents or pharmacologic stress. In this test, you have an injection of a radioactive material into the vein at rest that kind of moves around the body and hones in on the heart. When it gets into the heart muscle, it emits a low dose of an energy that we can detect by a certain kind of camera. And so we will do pictures before any stress, and then we'll do either the treadmill or a pharmacologic stress again. We'll wait some time during that stress. We'll give you another dose of medication, of the radioactive medication, and then we'll wait some time and put you back on the scanner, and we get a before and an after picture of the heart, and we can identify again whether there's been previous damage or if there's any blockages that may be decreasing blood flow that would need to be further addressed. This is a picture of myself at our newest cath lab at St. John Medical Center. It got placed about 3 years ago. And this is just going into the next step, coronary angiography or cardiac catheterization. This is an invasive procedure where we use IV dye or IV contrast, where we insert a small tube or catheter either through the wrists or leg, and we go up to the arteries that feed the heart, and we take pictures and see exactly whether there is severe blockage or not. We use X-ray to determine the presence or absence of blockage and how severe they are. The benefit is that we can not only identify, but we can potentially treat or stent or balloon at that time. There are also tools, if there is an uncertainty, we can do additional testing in the cath lab. But this is, like we talked about, an invasive procedure, so there's a risk of doing an invasive procedure, and we always have to make sure that we've talked to our patients about the benefits of the procedure and weigh those against the risk and determine for each individual whether it is a procedure we should pursue or think about other options. So let's kind of get into the treatment then. If we've identified different factors or how we look into this, what can we do to kind of either prevent or treat patients with coronary disease? Some of the dietary considerations, the American Heart Association and the American College of Cardiology has published guidelines where there is an emphasis on eating vegetables, fruits, legumes, nuts, and whole grains, as well as fish, replacing saturated fats with dietary monounsaturated and polyunsaturated fats, reducing cholesterol and salt, or trying to minimize, as well as minimizing processed meats, refined carbohydrates, and sweetened beverages. In terms of physical activity, both those organizations, again, recommend engaging in 150 minutes of moderate intensity or 75 minutes of vigorous intensity exercise per week. And this can be divided up in any way you'd like. For 150 minutes, it might be 5 times at 30 minutes a day, or it could be 3 times at 50 minutes a day, 3 days a week. And 75 minutes the same way. It could all be in one episode, or it can be divided. If you're unable to participate fully in those recommendations, then still engagement in some sort of moderate or vigorous activity for a shorter duration would also be recommended. And if you cannot even do that, just trying to decrease being sedentary. Instead of sitting there, getting up and walking around the kitchen table, or a path from your dining room through your living room and back, and set it at every commercial, instead of sitting on the couch for an hour. Anything is better than nothing. So I think that they identify that we can't all be going out and doing 150 minutes necessarily, but they say it's okay, go ahead and do something. What about weight and obesity? Weight loss is recommended for individuals with a body mass index of 25 or more. And that's a person's weight divided by the square of the height in feet. And these are calculations that you can get online and that your doctors can help you with at their appointments as well. It doesn't measure body fat directly, but it correlates to a risk of health problems. And so what can we do? We can engage in calorie reduction to achieve and maintain weight loss. And you can talk to your doctor about medically supervised weight loss programs or treatment options. What about type 2 diabetes? Diabetics, we know, have an increased risk of cardiovascular problems. We know that about 30% of all adults in the US will die of cardiovascular disease, but 70% of diabetics will. So we know that not only is this a sugar problem, but it really is a cardiovascular problem. So we want to have tailored nutrition plans focusing on heart-healthy diets to improve glycemic control or controlling your sugars, and to achieve weight loss if needed. We have the same exercise recommendations as we discussed earlier for diabetics, 150 minutes of moderate or 75 minutes of vigorous activity per week. There are a couple of call outs to specific medications, including metformin, which has been a medicine that's been around for quite a long time. And the reason that there's a call out from the American College of Cardiology and the American Heart Association is that there is a known decreased risk of atherosclerotic events or coronary events with the use of metformin. In addition, in patients with additional risk factors, other medications, such as some of these newer SGLT2 inhibitors or the GLP-1R medications, these also help to achieve glycemic control or sugar control, but also reduce cardiovascular risk. I don't anticipate you or want you necessarily to remember these, but I think what you should know is that if you are diabetic, you can talk to your doctor and ask if any medications are available that will also help, not only help your sugars, but can also help decrease your risk of cardiovascular problems. What about cholesterol management? This is always one that a lot of folks have a lot of thoughts about. Statin therapy for adults with an elevated 10-year atherosclerotic cardiovascular risk. We talked about that free calculator you can use. There are different guidelines. And if your 10-year risk is elevated, that might be one of the recommendations, is to start statins. We know that statins decrease not only your cholesterol, but also your risk of stroke, heart attack, or cardiovascular death. I try to explain to people a few different concepts. Number one, no one ever has high cholesterol in their death certificate as the reason for death. It's always these other things that cholesterol can lead to. So strokes, heart attacks. I don't care about your number. I'm not necessarily treating your number. We may talk about your number, but I'm really trying to treat as your risk, right? We want to decrease your risk. And we know that by lowering your cholesterol by certain means, and statins are one of those, that we can decrease your risk. So if we identify your risk as being elevated, then statins may be part of that treatment option. Statin therapy is also recommended for diabetic patients aged 40 to 75, regardless of your 10-year risk, going back to the idea that diabetics have increased risk of cardiovascular problems. And in patients 20 to 75 years old with an LDL greater than 190, so people who have a very high LDL, we really want to try to lower that because there has been a connection with a lot of additional cardiovascular risk when you have that high of an LDL or bad cholesterol. Moving on to high blood pressure or hypertension, everyone wants to know is, are there things we can do that are not medications? And there are. So there's weight loss, there's a heart healthy diet, there's sodium reduction or salt reduction, physical activity programs, and limitation of alcohol. Also limitation of certain medications like over-the-counter anti-inflammatory medicines or NSAIDs. We know that these can also increase your blood pressure. So there are things that are non-medicines. But we also do recommend medicines or pharmacologic treatment, we call that, for people with different findings, such as an elevated at the 10-year atherosclerotic cardiovascular risk, people with chronic kidney disease, and again, patients with diabetes. Tobacco is also something that I think we all are more aware of and we talk more about today than maybe we did 20 or 30 years ago. But I think it's important to still identify and talk with people about understanding why it is that a cardiologist may be talking to you about stopping your cigarette use or your tobacco use. Because there is this connection that the tobacco irritates the lining of the arteries and that allows more cholesterol to go in. And so I think understanding that is the first step, but also trying to talk to patients about what it is that is the most difficult part of quitting and how can we help you? Can we come up with a plan? Can we come up with some goals? And I think it has to be an open, honest conversation, right? I always tell people that if I sit and lecture to somebody about their smoking, they're going to come in next time smelling like cigarette smoke, saying they quit. That's not helpful for either the person in front of me or myself. So I think we have to be honest. We have to talk through these things and understand each other and try to figure out, is there a way that we can help each other get to that point where we can really decrease your risk? What about aspirin? Another hot topic that I spend a lot of my day talking to people about. In April 2022, the U.S. Preventive Services Task Force, again, published a report about primary prevention. I want to be very clear about this. Primary prevention means stopping your first event. So for those of you who are fortunate enough to say that you have not had coronary disease or a stroke, this is who we're talking about, or bypass surgery or stenting. We're not talking about people who have had those things. So if you've had coronary disease peripheral arterial disease, strokes, stenting, bypassing, now you would be lumped into a secondary prevention. So secondary prevention, aspirin is indicated. And so talk to your doctors, make sure you understand. If there's a question, make sure you understand, are we talking primary prevention, stopping our first event, or stopping a second event? But they came out with recommendations on primary prevention. Several studies have more recently identified that aspirin, although it does decrease the risk of stroke and heart attack, there is an increased risk of major and even fatal bleeding. And in one study, even an increased risk of cancer death. So we have to weigh the risks and benefits. And so the USPSTF did recommend individual decision-making in patients 40 to 59 years of age with increased cardiovascular risk, talk to your doctors, but really discourage the use for patients 60 years or older, regardless of their cardiovascular risk, for primary prevention, citing the increased risk of major and even life-threatening bleeding as a higher risk than the benefit of stroke and heart attack reduction. There's some thoughts of why this might be. Some of the older trials that showed a benefit in comparing the risk and benefits were trials that we did not use. We didn't have people on medications such as cholesterol medications, and we weren't as aggressive with blood pressure treatment goals. So some have pointed to the idea, well, maybe we're already decreasing that risk and we have less of a benefit by the aspirin because we've already lowered our risks further by using these types of medications. And maybe that's why we're starting to see some of the side effects more so than the benefits. So what can I do now? You know, I've learned this information. What do I do now? I think this gives you an opportunity to take some of the tools we talked about today. Speak with your primary care physicians or providers and inquire about what you did learn today. Talk or ask them about your 10-year risk. Ask them if there are things you should be considering in terms of blood pressure or cholesterol management. And you can also talk to them about whether you are a candidate for the no-cost coronary calcium scoring CT at UH. I think these are all things that you can speak with your providers about. And lastly, come see us. You know, we are here for you. The group of cardiologists and nurse practitioners and specialists at the UH Harrington Heart and Vascular Institute, we're here. We're members of your community. We're a part of the community. We're here for you, and we want to help. And I just wanted to have a little call out to the group of wonderful people I work with every day here at UH St. John Medical Center. Also to remind all of you that we have a full array of services, including general cardiology, interventional cardiology, electrophysiology, heart failure, oncocardiology, vascular services, vascular medicine, vascular surgery, cardiac catheterization labs, EP labs, echo and vascular labs, and our wonderful people at the Cardiac and Vascular Rehab Center. So I wanted to make sure that you're aware we are here for you and we're happy to help in any manner we can. So at this point, I'm going to turn it back to Tiffany.
Yeah, thank you. And thanks. What an impressively large group that's been built there at St. John. That's a wonderful resource on the West Side. Thank you for sharing that and for all the information so far. And we do have some questions rolling in through the chat, through the Q&A. So I would just invite any other audience member who has questions to put them in the Q&A. And we'll get started. So Dr. Coletta, we always get a lot of questions around calcium score. So I'm going to start off with a few related to those. You mentioned it's a test that can help evaluate your 10-year risk. We've had a couple questions on the actual number. So what does a calcium score of 1200 mean? Does it mean automatically heart disease? And what should I do?
Right. So I think this is always the problem. If you get a test, what do we do with the results? And so, you know, the problem is that everyone is unique. As soon as we think we know everything, the good Lord, you know, taps us on the shoulder and says that's not always the case. That's what I believe. But how I've described this to different people is that a score over 400 demonstrates an increased risk of cardiovascular events. And what you want to do is to reach out and speak to a specialist who can walk you through that information. I've tried to explain the idea of coronary calcium in a couple of different ways. If you imagine a pipe, a PVC pipe, let's say, and I gave you a handful of silly putty, and I told you that this silly putty has 1,200 units of calcium, whatever that means. And I asked you to put this piece of silly putty within the pipe. There are several ways we can do this. We can ball it up and plug up that pipe in one little spot, but you can also take it and roll it out into a very flat ribbon and put it along the whole pipe. And in both cases, you have 1,200 counts of calcium. And so I think it depends. Everyone is individual. We have an individual risk, and there's individual factors that may make a score of 1,200 something that we are more worried about or less worried about. Typically with elevated scores, we're going to talk about additional testing, kind of turning on the faucet like we talked about before. We have a picture now, a diagram that there's calcium. We've got to test the system. We've got to do stress testing or potentially consider cardiac catheterization. But these are individual treatment options that you need to address with a specialist at that point.
Thank you. That's a great way of describing it too, that it could be spread out versus kind of all in one section. So
Sure.
Is it at the end of the day, though, is it always related to heart disease, or are there any other potential influencers for what could cause a high calcium score for someone?
There are calcium by itself, like I was alluding to before, indicates that there has been this invasion of the artery wall with white blood cells and cholesterol, and that they've come together and deposited calcium. So at any degree of coronary calcification, there is, if we were able to take that artery and put it under a microscope, we will see that there's cholesterol buildup. It may be from things other than traditional coronary disease, inflammatory processes, we're on that indication for the coronary calcium score. Those can increase the risk. High blood pressure, smoking, all of these things can increase that risk of invasion of the artery. But the calcification itself does indicate that there has been some degree of atherosclerosis in those arteries.
Okay, thank you. Thanks for explaining that. So let's say I have one done. How often do I need to have it repeated? Every few years? Every 10 years?
Yeah, that's a great question. There are ongoing research. Researchers are looking at this, ongoing studies, trying to identify, what do we do with an elevated score? My personal, or what do we do with a zero score? Where do we go? What do you do if it's in the middle? There's a lot of little nuances here. And I think the first thing I would say is if you have an elevated score, we know that calcium scores will invariably go up. You won't see someone whose scores start coming down. So if you have an elevated score, there's no real role that I'm aware of repeating that score. Some people are trying to see if you can repeat it, and it changes at this point, how much it changes over what time period. But at this point, there's no consensus. So if you have an elevated score, my personal recommendation is that we do not need to repeat it. We've identified that you're at an increased risk for problems. We have to decrease your risk. We're not looking to do that by what the calcium counts are. We're using the blood pressure, the cholesterol, your weight, different things, lack of symptoms. We're identifying and trying to treat those risk factors at that point. If you have a zero score, there still could be cholesterol. It just may not be calcified. So we still have to identify, are you someone who we should keep an eye on in terms of an elevated risk, or is your risk acceptable where you may not need a cardiologist, but we need to make sure you follow with your primary care. And then there's almost everything in between. So currently, I do not know of any recommendations that say we have to repeat it every 3 years or 5 years. I think there's going to be more to come on that. But I think getting the one value, talking to your doctors about that and trying to figure out what we need to do with that, at least at this time, is where I would start off.
Okay, great. Thanks for that clarification. And maybe it's because it's called a calcium score, but we do have questions around, calcium content in foods. So does
Sure.
that relate to that? Like, should I avoid foods with a higher calcium content?
Sure, it's a great question, and I apologize because I usually talk to my patients about that. And one of the lines I say is that this has nothing to do with the calcium that you're consuming. So what happens is that when that white blood cell eats that cholesterol particle, it becomes a bone-forming cell, sort of. And so that's where the calcium comes from, that change in that cell, not because you had a glass of milk yesterday. So you don't have to necessarily change now. Again, if you're trying to decrease your cholesterol intake, that's one thing, but specifically calcium, no, we're not saying that you should start limiting your calcium if you have an elevated score.
Okay, one final question about calcium score before we shift gears a little bit. Let's say, I have my score and I start taking a statin. Is it something where I can affect that calcium score? Like, do I want it to go up or down? Is this like any other number that I'm monitoring? How does that work?
Another great question, and I think we're still learning. We do know some trial data from certain studies that do demonstrate an increase calcification score in patients with higher intensity statins. What was interesting about some of the results of those studies is showing that even though the calcium score went up, and we've had this baseline thought that the higher your calcium score, the higher your risk. What was found in the study is that if you took people with elevated scores and you put them on higher statins, the people on the higher statins would develop higher numbers of calcification over a shorter period of time. However, they were still at a lower risk of hard endpoints, what I call hard endpoints, strokes, heart attacks, cardiovascular death. So despite the fact that their calcium numbers went up higher than the people not on those high intensity statins, their risk of events decreased. So again, it's not straightforward. It doesn't necessarily fit what we would think initially, but it kind of goes back to the risk. If we've identified you at a high risk, we don't know that using repeat calcium scores to guide therapy necessarily works. And in some cases, like high intensity therapy, statin therapies, we will make your calcium go higher, but you'll be at a better point at a less risk for cardiovascular events by putting you on that statin.
Okay. Thank you for that information too. So I'm going to shift off of calcium scoring for just a moment to try to address some of these other questions. And a couple of them relate to the symptoms, going back to the early warning signs. And we had one audience member who mentioned that, when she was 48, she didn't have chest pain with her first heart attack. She had pressure in the right side of her back that felt more like a bubble. So you had mentioned chest pain or discomfort. Sometimes we hear about people feeling dizzy, even, let's say, but you can feel dizzy just by, whatever, not eating enough, not being hydrated. So what's happening here? Will you always have chest pain along with, indigestion or feeling fatigue? Or could you have no chest pain at all?
Right. I would love to tell you that if you have A, B, and C, that this is heart and get to us right away. And if you have D, E, and F, you don't. Unfortunately, there is no set cookbook, and everyone can experience things differently. So I think that if you have symptoms that are concerning to you, something doesn't feel right, talk to someone. Get to either your primary care physician. If you have a cardiologist, reach out to them. After here, first off, we don't all know all the answers. And so, I recommend to people, even if I'm telling you that my level of suspicion at this time is low, let us know if you don't get better. If we think that there's a low risk, but your symptoms persist or worsen, we can take next steps. If we've even done a stress test and we don't identify a problem, there's no stress test that's 100% accurate. And so I tell people that if they have a normal stress test, what a normal stress test means, it means that the likelihood of a severe blockage is low. It doesn't mean there are no blockages. It doesn't mean there's absolutely no risk for severe blockages. It says that the likelihood is very low that there is. So if you are having continued symptoms, we can take additional steps. If you're having symptoms that are exertionally related, relieved with rest, these are symptoms, even if they're not that elephant on the chest, if it's your right shoulder that's hurting or some other symptom, but you notice that it's happening with activity and being relieved with rest, come and talk to us. This is part of what we need to do, is to help you walk through that idea of what's going on and gives us an idea, should we be concerned or not? And do we need additional testing or not?
Okay, thank you for that. And I have a couple questions related actually to your note about moderate intensity exercise. So that could be somewhat vague for people. So I think what the question is what is considered moderate intensity, and is there a target heart rate for moderate versus vigorous?
There are several different ways to look at this. What I've told people is that it's heart rates are fine to try to look at and trying to identify your age, your predicted maximal heart rate. You can take 220 and subtract your age. And we can say to try to get between 70 and 80% of that number. And so if you're a mathematical person and you really love the idea of all these numbers, go ahead and do them. But I think how I explain it to people is moderate exercise is exercise that if you were doing it with somebody next to you, a friend, as you were doing it, if you're really kind of in that moderate range, you shouldn't be able to have these kind of full sentences without having to take a breath, right? You should be going and thinking that I have to take a breath without finishing my whole. To me, that's the kind of exercise I'm talking about, where you should be able to feel a little breathless while you're doing it. And vigorous activity is where we do start looking at, you can start talking about heart rate ranges. You can talk about getting that heart rate, at 80% or higher. This, you really aren't having conversations. You're kind of focusing on your exercise at that time. So whether that's biking or rowing or swimming or walking, we're not saying that it's any one individual activity, but it should be consistent throughout that time. So if you're saying 30 minutes, we're doing 30 minutes of activity. You may do, 10 minutes of the bike and go right over to a treadmill. As long as you're not stopping, hitting the water cooler, sitting down for 10 minutes. If you're kind of moving station to station, that's fine. But we're talking about uninterrupted 30 minutes at a time, let's say 5 days a week.
Okay. Thank you, Dr. Coletta. And this is a particularly, well, it's a little specific, but if someone had asked, is it an issue to have normal systolic and low diastolic 129/51? Is that something they should get checked?
What I always will say is that if you're concerned, just ask, speak to somebody about it, get a once over. There are conditions where the difference between the top and the bottom number, which we refer to as a pulse pressure, elevated pulse pressures. So a difference between those two numbers that are really high could implicate different disease processes, could be totally normal. So by a specific number, those numbers don't concern me, but if there's a concern, ask your primary care.
Okay, that's wonderful. Good advice. We do have a couple questions about aspirin. Someone says, I was prescribed for it per my doctor for FMD, fibromuscular dysplasia, and they're over 60, they're taking 81 milligrams. Should they be concerned based on these new guidelines?
Right. I think that if you are being told that you need aspirin for fill in the blank, right? FMD, even you will hear some gastroenterologists talk to people after colonoscopies that it can decrease the risk of colon cancer. If your doctor's telling you that they're doing it for an indication, you can ask them, are you sure, is this to prevent heart attacks or is this for something else? And if they're telling you it's for something else, follow their recommendation. If those guidelines are very specific to saying, hey, you came to see me and I said, start this aspirin to decrease your risk of stroke or heart attack. In that situation, over the age of 60, the U.S. Preventive Services Task Force discourages, says, do not use that. These are always conversations you have to have with your physicians, and you may feel, and your physician may feel strongly because of some other circumstances that you may choose otherwise, but these are guidelines. And so again, if you are being told that you need it for a specific condition, I would encourage you to continue it at least until you go back to that provider and make sure you feel comfortable with the reason you're taking it.
Okay, thanks. So that helps address questions that we had from someone about prescribing statins for patients older than 75. It sounds like that's a personalized conversation to have with your physician.
Tends to be, when we're talking about primary prevention, so if we're not talking about people who've had previous issues, primary prevention studies looking at the use of certain cholesterol medications use a certain time frame to see if there's a benefit. And so if we're looking for a 10-year reduction in certain endpoints, we may say that a 90-year-old may not need a statin because, we may not be trying to achieve 10-year reductions, let's say. Everybody is personalized, but if you've had an event, let's say you're 72 and you come in with a heart attack, different story, right? That is no longer primary prevention. Now we're going into secondary. Secondary is a whole different conversation, nothing that we discuss specifically here.
Okay, thank you. That's a good point again about primary versus secondary. So someone had mentioned that they've taken a baby aspirin for years. It's kind of become a
Right.
security blanket of sorts. But now
Right.
they're wondering about their bleeding chances down the road. Does data have, is there anything in the data that aligns or talks about bleeding chances or risks, and what kind of conversation or should they be having with their doctor?
Right. I think that I would definitely address that with your physician. There's the old adage, you've never had a problem until you have the problem. So you could live 25, 45, 85 years and not be diabetic until you then are diagnosed. And so you could be on aspirin for years and years and years and never have a problem, and then have a gastrointestinal bleed. So I think, again, this is something you need to talk to somebody about. It's not that they found that if you were on it for 10 years, you were immune to the risks. It's something that persists. And so I think having that conversation with your primary care provider to go over those risks and maybe strategies of, if we're going to stay on it, let's look for these few things or try these few things to feel more comfortable about staying on it. But again, based on recommendations, if you haven't had a stroke or heart attack, the recommendations would probably be to stop it. But I'm not telling that person to stop it. I would tell them to speak to their physician specifically.
Okay, thank you. And just a question about timing in terms of taking the baby aspirin. Is it better to take it first thing in the morning or before I go to bed at night?
With aspirin specifically, I don't know that there has been any data to say it's better at one time of the day or the other.
Okay. We did have a question about how a statin works to reduce your cholesterol. Do you have any brief information that you can just review on that, how a statin actually works to reduce cholesterol?
So I think that there's two parts here, and I almost would say, instead of focusing on the cholesterol, some people really want to understand, why are we using this to decrease risk? And so moving away from the cholesterol reduction for just a moment, what I would say is that part of the effect of a statin, different than a lot of the other cholesterol medications, is that there is some sort of anti-inflammatory effect, that there is an ability of the statin to decrease the inflammation of the arteries and decrease that movement of cholesterol into the vessel wall. And so I more importantly, in my opinion, than how it works specifically, is to understand that it has an additional effect that we don't see in a lot of these other medications that can lower cholesterol. And so you could find that the FDA approval for certain medications, let's say fibrates, is to reduce cholesterol, but that we can see that the FDA approval for certain statins is that it decreases cholesterol and decreases cardiovascular risk. So I think that's where I want to focus people to say, instead of trying to nitpick how it works on the cholesterol, that it has this added benefit, and that's why it is in the favor of so many cardiologists and primary care physicians.
Okay, that's an important description. So thank you for sharing that. Now we do have one person who mentioned that, they had a stress test and they were told they needed to do a follow-up stress test. It obviously makes somebody nervous. They go to the follow-up and it's normal. What does this mean for follow-up? How does this even happen in the first place, that it's abnormal and then normal the second time?
There are several factors that go into a stress test, and it's not, unfortunately, it's not simply it's a yes or a no. In terms of treadmill stress testing, we look at heart rates, we look at EKG changes, we look at whether there's chest pain and what type of chest pain. We could understand how long they were on the treadmill, use all of this information to get a score that will give us an idea of the likelihood of a problem. You could have a high likelihood, you could have a low likelihood, you could have an intermediate likelihood. So you may have a quote unquote abnormal stress test with an intermediate score. But there may have been something that you felt you needed additional imaging for, and so you might do a second stress test. Once again, no stress test is 100% accurate. So if there are any concerning signs, you may go on to a different type of stress test. And those different types of stress tests may change how accurate is the word I'll use, but it's not truly accuracy, it's sensitivity and specificity. But for us kind of just talking, I think just to know that different tests give you different information. And you may come up with a test that's slightly abnormal and repeat a different type and find that it's more reassuring. But once again, I've had patients who've had normal testing but have persistent symptoms, and they come back and we talk about doing additional workup and find problems, even with normal stress tests. So again, I'm not trying to say don't trust the stress test, but if you're having symptoms or concerns, go back to your doctors and talk to them about these things. But even though stress tests do help, they're not necessarily the end all be all when it comes to whether or not there's a problem.
Okay. So we have a few questions. One actually around, whether they should be concerned or not. Should they seek consultation with their physician? They're a 59-year-old African-American female. In the past couple months, this individual has gained weight, looks about maybe 12, 13 pounds. And they're noticing an increase in exhaustion when climbing the stairs and urge to sleep during the day. Is that cause for concern? Should they be reaching out?
Sure. It sounds like I would advise at that point, yes, you should reach out, speak with your primary care physician. If there's a change from your normal, whatever that means to you, if you feel like something has changed, reach out, talk to your at least start with your primary care physician, and they may direct you to come back and see them again in a short period of time, or have routine blood work or an x-ray of some sort. So there's always different things that they can do to try to identify what might be going on. But yeah, that sounds like something that you would like to reach out to at least your primary care physician and go over and see if they would like to do any additional testing.
Okay, thanks, Dr. Coletta. We have a couple minutes left. I just have maybe a couple questions back to calcium score if we can, since there's a few in here. Sure. And then we'll have to wrap it for today. But there were a couple people who asked. So let's say I have a high calcium score, 3,500, 3,500 sure. is my score. I have documented blockages, 70% in my coronary arteries, but I don't have any symptoms. So am I as maybe at risk as someone who does have symptoms? Is different risks, same score, let's say, but do the symptoms make a difference in the risk?
Yeah, so a couple of quick little things. Number one, if we have known coronary disease, a calcium score doesn't help us. That's not been looked at. That the data I was presenting is not related to that specifically. So if we know that there's blockage, or if you've had a coronary stent before, your calcium score will be very high. It will address that stent as metal, and you'll have a very high number. So if you have an elevated calcium score, is your score that's equal to your twin brother's exact same score? Are you both at the same risk? No, the risk is above a certain percentage, right? So if you have an elevated calcium score, you have an increased risk of cardiovascular events over the next year is really what it identifies. And that risk is over a certain percentage, over 4%, let's say. Doesn't say that it's 100%. It doesn't say that it's 4.2% versus 8%. There are different differences in whether someone is an active smoker or a diabetic that has uncontrolled diabetes or blood pressure is out of control. There are other things that might push you into a higher risk or into a lower risk. So yeah, the number by itself identifies that you're at risk, and then it's time to go speak with a specialist to understand how much of a risk that is, and is there anything else we need to do?
Okay, so it sounds like that maybe then on the flip side, if someone says, hey, I've got a calcium score of 0, I eat whole food, plant-based diet, but I have an inoperable carotid blockage. So now they're on 20 grams of Lipitor. So this person was saying, why am I taking a statin if all of those other things, I'm exercising, are so good?
Yeah, so there are other reasons. So, and that's great that person has a 0 calcium score. There are people who, even though they have a low calcium score, for one reason or another, they may have a different test, and they do identify coronary disease. It's not very common, but we definitely have seen that. But if you have blockage in other artery systems, a carotid, a leg artery, an arm artery, a brain artery, statins can decrease the risk of complications from that as well. And so just because a calcium score is 0, that's fantastic from the coronary standpoint. But if there are other reasons to start a statin, we know that they will decrease strokes. In that individual situation with the carotid disease, we know that there will be a reduction in stroke if we can stay on a statin. So I think it doesn't give us all the information, the calcium score.
Got it. Well, Dr. Coletta, this has been fabulous. There are obviously a lot of questions from the audience, and we really appreciate your time in trying to address as many as came in. There are still a few left, so we'll take that in consideration for future planning. But thank you so much for your time today. And I did just want to mention a couple notes for the audience. Today's webinar was recorded and it will be posted on our website. You will receive an email with the link to view it once it's available. And before you log off, if you don't mind, you'll notice a post-session survey pop up on your screen. We just ask that you take a moment to provide your feedback to help guide us when we're putting together our future webinar topics. And that wraps us up for today. Thank you for attending. Have a great afternoon.
Thank you, everybody.